So another area of opportunity, and I think part of integrated care, especially as the urology world gets more into the management of patients with advanced prostate cancer, castration-resistant metastatic prostate cancer, is that now, as we all know, as we all have used clinically, we have newer oral therapies that the urologist, I believe, we all believe, should be delivering, should be prescribing, should be managing these CRPC patients. So with that as a backdrop, one of the things that now is coming to light, especially opportunities for the urology practices, the urology groups, again, as part of our integrated model of delivering healthcare, is the incorporation into your practice of a dispensing pharmacy. And again, most of this is designed primarily for a seamless integration of therapeutics and management for these advanced patients. So again, Sandy, you are, again, really always looking at new opportunities, trying to incorporate care. Tell us about your experience at Chesapeake right now with dispensing pharmacies.
Well, Neil Shore came a couple years ago to Chesapeake, and his point was that these are our patients, this is our disease, and we need to control the prostate cancer patients. So I think many of the things we're talking about is how that we can control these patients, and not control in the sense of, you know, where those dollars go, but how can we best take care of these patients? And I think that whether it's MRI fusion or it's dispensing pharmacy, it's all how do we best take care of the patients? Because the patients have been with us sometimes for 10, 15 years. They know us, they trust us. When we were sending them out to other facilities for care, they didn't have that confidence of treatment. And the infusion pharmacy or the dispensing pharmacy is just another way that those patients can remain in the practice, remain with the doctor who's been treating them for 15 years, and feel comfortable as their disease advances. We started the infusion part of our practice about a year ago with Provenge, and we have moved it over in the last several months to dispense some of the oral medications that are available for advanced prostate cancer. We have found the patients really like the service that they get. It's no different than going to a pharmacy, but they come to the doctor. They can have their questions answered by the doctor who's been taking care of them. We have well-trained people who have been in the pharmacy world for many years, and they are providing an incredible service to these patients.
Yeah, I think it's important, especially for the viewers, to understand that this is an entirely different model. So we know that infusion, whether it be Sapulacel T, whether it be zoledronic acid, pretty much that falls under major medical. Now, when you talk about setting up the dispensing of oral agents, that's going to come into the area of a dispensing pharmacy, specialty pharmacies, and there's a lot of nuances, there's a lot of regulatory that goes into that. But again, I would wholeheartedly agree on the thing, Gary, that again, this is part of what we need to do in order to manage these patients better.
Well, I absolutely agree with Sandy about the comprehensive nature of the care that we have to offer and the importance of placing this service into that comprehensive care. Now, when it comes to dispensing pharmacy, you will find a lot of variation state to state, and there are a lot of pharmacy board regulations that are state law related. Groups will have to be very cognizant of what they can do in their state. We are embarking, we're always behind Sandy, let's be clear, but we are embarking upon this path ourselves, and I agree with Sandy 100%, especially with the oral agents for MCRPC, which I do treat a number of, thanks to Neil, bringing a lot of this into our practice. And these patients need to be closely monitored. We need to be sure that they're really staying on their Zytiga, for example. We need to be sure they're getting their lab work. We need to be sure they're taking their prednisone. And if we don't have control over this process, we can't really appropriately take care of them. And that's a real driver for us. So I think the day for a specialty dispensing pharmacy is coming for most of us, if allowed by law. And I also want to say one other thing. When it comes to dispensing, there are some non-advanced prostate cancer products that you can dispense that are going to be a very great service to your patients. Certain generics that you will be able to dispense very easily to them that are common in the urology clinic. I don't want to use any particular names right now, but I think you can imagine products for erectile dysfunction, products for prostate obstruction, and others. This will be important convenience for them to be in your clinic and be able to pick these up right when they're there, and I think this is coming.
So Neil, because again, you have been on the forefront of pushing therapeutics in the advanced CRPC space. I think Gary makes a big point is that I believe it's important for groups to potentially offer this if you've got that patient volume to be able to do this. But as Gary appropriately said, this is not dispensing these drugs, these therapeutics is not like putting somebody on an antibiotic or an anticholinergic and saying, hey, I'll see you in 30 days or 2 months. I mean, monitoring is a big thing for some of these drugs, correct?
No, the points are so well said. You know, there's compliance. If you're going to treat, you know, advanced cancer patients, you want to do it with tremendous conviction and a dedication. I think having the volume and looking at if it's worth your initial startup of time and cost, which clearly it is in most large groups, the big advantages are it's a greater service to the patients as part of our integrated models that we clearly champion. There's ability to monitor for safety, registries, aggregate data, and patients will really actually like it. It's just much more convenient for them. And as you said earlier, a lot of these advanced oral therapies and some of the infusional and even some non-oncolytic products that Gary alludes to, you can't get them by writing a prescription. And by doing it in-house, where you can really control it, I mean, it makes us better deliverers of care.
Could I add something? I mean, I agree
because
with you.
it's a little challenging for you. You're geographically spread throughout all of metropolitan Chicago, but I know you guys are looking at this also.
Yeah, we've actually got it started. And again, we dispense through one center. We have pretty much a cancer center, and that's where we do our infusions and we do our dispensing of our oncolytics. And I think what this really is, as everybody's alluded to, is another piece of the integrated care puzzle. Everything's been stated here that it's important because we have much better patient care, we have much better follow-up. We really can now track these patients as opposed to them just getting something from a specialty pharmacy where we don't really know if they're getting their medications, if they're taking their medications. And I think that just like everything else, this allows us to keep these patients in our practice and give us a standard where we can follow them. Whereas we all know if they'd go out for radiation therapy, whatever, oftentimes they'd go out, you wouldn't even know about it. You know, maybe you'd get the patient come back months later and tell you, or you'd get a letter 6 months later and it wasn't even on your radar screen. So I think this is, again, as I said previously, just another piece of the puzzle for us to provide much better patient care by better tracking and the ability to keep patients in our practice.
Yeah. I think, Sandy, you made a great point, and I think the urology world, I think they underestimate, they undervalue the doctor-patient relationship they have with their cancer patients, whether it be prostate, bladder, kidney. I mean, I would suspect that most of us, and you and I have had this discussion about tracking how often these patients are coming back to our office. As you said, from the time that you make the diagnosis of prostate cancer, because the patient comes in, not because they have prostate cancer, you've ushered them through this whole elevation of their PSA to the time they become metastatic. That patient is being seen in your office. The average, I believe, is like 7 to 9 years. So they have a comfort level, they have a trust. And I think the urologist, the urology world needs to understand that our patient relationship, our ability to continue to keep these patients, to monitor these patients, because they have an inherent trust of their urologist to manage their disease. I think it needs to be completely understood by the whole urology world.
You know, one of the great challenges we have is getting patients to do what we believe is in their best interest. And specifically with this disease, because in the advanced stage, you know, people die of this, as you know, 29,000 men will die of this cancer. And I think that we can definitely, you know, lengthen that time that to that time with what we're doing here. And getting them to adhere to what is in their best interest is really paramount right now. We have a great opportunity to do that now, and all the things we've spoken about, but this specifically, keeping the patients in our integrated care model to the best of our ability is right for patient care.